All right, let's get right into it. Today, we're not just going to talk about a disease, we're going to solve a clinical mystery. We're going to follow a patient's story, piece together all the clues, and crack the case of rheumatoid arthritis.
So, our story starts here. Picture this. A 42-year-old woman walks into your clinic. For the last 3 months, she's had this nagging joint pain. She feels incredibly stiff every morning, and it takes more than an hour to loosen up. On top of that, she's just wiped out, totally fatigued. Now, these aren't just random complaints. They're our first crucial clues.
So you do the physical exam, and you notice her wrists are swollen and tender, and critically, it's symmetric. It's happening on both sides. It's also in the small joints of her hands, specifically the MCP and PIP joints, the knuckles and the middle joints of her fingers. This pattern is just classic. So, what's at the top of your differential? Let's figure out how we get there.
So here's our game plan. We're going to start by recognizing the pattern here. Then we'll rule out other things that can look a lot like this. After that, we'll get the tests to gather evidence, connect all those clues to lock in the diagnosis, and finally, we'll talk about why getting this right and getting it right early is so incredibly important.
Okay, first step, we have to figure out what kind of problem this is. Is it just wear and tear, a mechanical issue, or is there inflammation going on? Well, her story gives us a huge clue.
And this right here is probably the single most important clue she's given us. That morning stiffness, lasting over an hour. That screams inflammation. See, inflammatory cells and fluid build up in the joints overnight when you're not moving. That's what causes that prolonged gel-like stiffness. It's not the kind of ache you get after a workout. This is different. So when we put our patient's story up against the classic pattern for rheumatoid arthritis, it's a perfect match. Her symptoms are chronic. They've been going on for more than 6 weeks. Check. She has that classic symmetric small joint pattern. Check. We've got the prolonged morning stiffness. Check. And she has systemic symptoms, like that fatigue. Check. The whole picture is pointing straight at RA.
But hold on. A good clinician never gets tunnel vision. Before we lock in our primary suspect, we have to consider the lookalikes. We've got to rule out the mimics.
Now, the most common mimic by far is osteoarthritis, or OA. And this table breaks down the differences perfectly. RA loves the MCP and PIP joints. OA, on the other hand, usually goes for the DIP joints, the ones closest to your fingertip. The stiffness? In RA, it's over an hour, and it's worse after rest. In OA, it's pretty brief, usually under 30 minutes, and it's worse after you've been using the joints. And when you feel them, RA joints are soft, warm, kind of boggy. OA joints feel hard and bony. Our patient's signs and symptoms are all lining up in that RA column. So here's a huge clinical pearl for you. If you see the DIP joints, those end joints of the fingers, are involved, you should immediately think of osteoarthritis or maybe psoriatic arthritis. It's almost never RA. That little tip can save you a lot of headache and really helps narrow down the possibilities.
Okay, so we've built a really strong case based on her story and the physical exam. Now it's time to go to the lab and get some imaging to gather the hard evidence we need.
And our workup is pretty straightforward. Step 1, we're going to check for general inflammation with an ESR and CRP. These basically tell us if the body's immune system is fired up. Step 2, we're going to look for the specific autoantibodies linked to RA. That's rheumatoid factor and, even more importantly, anti-CCP. And finally, step 3, we'll get some baseline x-rays of her hands and feet to see if there's any damage yet.
And the results are in. Her ESR and CRP are both high, which confirms there's a significant inflammatory process going on. Her rheumatoid factor is positive, but here's the kicker. Her anti-CCP antibodies are strongly positive. This is exactly what we were looking for.
So why is that anti-CCP result such a big deal? Well, think of it like this. Rheumatoid factor can be positive in a bunch of other conditions, and even in some perfectly healthy people. It's a clue, but it's not definitive. Anti-CCP, on the other hand, is way more specific for RA. A positive anti-CCP is like finding a fingerprint at the scene of the crime. It's a really strong piece of evidence.
So, what about those x-rays? Here's something you have to remember. In early RA, the x-rays are often totally normal, and that's okay. We're trying to catch this before the damage happens. If the disease was more advanced, we'd start to see things like the joint spaces getting narrower, or those classic marginal erosions where the bone gets eaten away.
All right, we have all the pieces of the puzzle. Let's lay them all out on the table and put this case to bed. So let's recap. Clue number 1 was the clinical picture itself.
We established a clear pattern of symmetric, inflammatory arthritis hitting multiple small joints. That was the foundation for everything.
Then, clue number 2, the lab evidence of inflammation. Her high ESR and CRP confirm that this isn't just a local joint problem, it's a systemic process, which totally explains why she feels so fatigued all the time.
And finally, clue number 3, the smoking gun. The serology, that positive and, more importantly, highly specific anti-CCP antibody. That's the piece of evidence that ties it all together and points overwhelmingly toward one diagnosis.
So we put it all together, and we have our diagnosis: rheumatoid arthritis. And I want you to notice that key phrase on the slide. It is a clinical diagnosis. It's not about a single lab test or scoring system. It's about being a good detective, taking the patient's story, the exam findings, and the lab work, and weaving them into a single, coherent picture.
So, we've solved the mystery. Case closed, right? Well, not quite. The truth is, the most important part is just getting started. Making this diagnosis early is a race against the clock.
And this is why. If you don't treat RA, it's not just about having sore joints. The constant inflammation can lead to irreversible joint destruction and permanent deformities. But the damage goes way beyond the joints. That same inflammation speeds up heart disease, increasing the risk for heart attacks and strokes. It can lead to osteoporosis. It even increases the risk of certain cancers, like lymphoma. The stakes for our patient couldn't be higher. And that brings us to our final, all-important question. We've locked in the diagnosis. We know it's at stake if we wait. The race to stop the damage and control this disease is officially on. So, what do we do next? That's the question that moves us from diagnosis to action.